Okay, let's start this podcast for Chapter 4. In your textbook, the chapter is entitled The Patient. There are about 23 pages in this particular chapter in the required textbook. There are 17 learning objectives. I would state simply, as far as the learning objectives, that a lot of this is probably, in a nutshell, one of the more important chapters in the textbook. We'll be talking a lot about theory and a lot about issues like adherence, which are important to take care of your patient, the healthcare needs. These will also be discussed in your communications course in the spring. As we go along, there will be 5 quiz questions for IRAD number 4, and I'll try to make the hints as clear as possible. So as you're taking notes, you might want to jot these down on your outline. Again, we're going to be talking about the patient. A patient used to be considered someone under the care of a physician, but now it is anyone under the care of any healthcare provider. You should note the grading of America, and that by 2040, 20% of our population will be over 65. This is not only a phenomenon here in the United States, but all global. It's the fastest growing segment. The fastest growing segment is in the over 85 years of age, the old, as they are called, as opposed to the young old, which is around 65. This puts increasing financial pressure on the healthcare system, especially Medicare. And all these different kinds of healthcare providers are augmenting or supporting the physicians. So it's important for you to know what you're talking about as far as theory and the concepts that affect patient care. In the healthcare environment, with improved public health measures, technology, which includes drugs and longer life expectancies, healthcare needs have shifted towards managing chronic disease and disability, not disease states and acute issues. Despite efforts to emphasize prevention, the healthcare system is still primarily designed to care for the sick, a sick care system rather than a preventative care. Patient expectations, there's a sense of consumerism. Access to information is improving for both patients and practitioners. There are self-care facilities on the internet and popular media, advertisements on TV, magazines, etc. help. It also may increase demand for these goods and services with direct-to-consumer advertising and popular media and images. Now, a quiz question on your IRAD number 4 will involve the concept of rural healthcare, how people out beyond the urban environment, beyond the suburbs, how they get care. And healthcare, I would just say, those services to patients in more rural areas is affected by a number of things, including the number of qualified healthcare providers, patient, their economic situation, and variation in the health services reimbursement. So if you look on table 4.2, that appears on page 120 of your required textbook, you'll see that access to access to care and treatments influences patient adherence. So in rural areas, it's especially precarious. There's different models of care that are discussed in the textbook. Here are 4 of the more prominent. There's the Saz and Hollander theories that take care of 3 models, cover 3 models: activity, passivity, guidance, cooperation, and mutual participation. So as you move from activity, passivity to mutual participation, there's more engagement of the patient. There's a consumer model, much like if you were buying any product or service. There's the patient-centered model where you focus, the pharmacist, the physician, the nurse, all center their care on the patient. And then there's a biopsychosocial model that takes into account a lot of different attributes of the patient, including the kinds of support that they have that affect how they think about their adherence and so on. Again, the Saz and Hollander, those 3 models. In the activity, passivity, the patient is passive recipient of care. There's little communications, and it's likened to a parent-infant relationship where the healthcare provider, like the physician, is talking down to the patient. There's the guidance cooperation model where the patient defers to medical expertise, communication, and more independence input. It's likened to the parent-adolescent relationship. And there's the mutual participation, which is the one you would like, where the patient and the physician are interdependent, but they must communicate. There's the consumer model, greater patient autonomy and decision-making. There's informed and skeptical buyers of medical care, and it reverses traditional physician-patient balance of power where the patient is in control. The patient-centered model is a holistic approach where all aspects of care are addressed, taking the patient's point of view. In contrast to the disease-centered care, where the focus is on the accurate diagnosis and treatment of organic pathology until cure is not possible. Finally, there's the biopsychosocial model that takes into account health and illness as a product of a person's physical context, their social context, their emotional state, and their psychosocial state. Behavioral and psychosocial data incorporated into the analysis of the biochemical understanding of illness. So as the healthcare providers get to know the patient, they make notes of all of these contexts or all these states to better treat the patient on their terms, patient's terms. Adherence. Now, compliance is a term that has fallen out of favor, so you really shouldn't use the term compliance anymore. It connotes the patient following or complying with the health professional's recommendations. Adherence, on the other hand, implies a patient choice in making the decision to follow the health professional's recommendations. Factors influencing adherence include the health system itself, the social and economic aspects of the patient, condition-related. So, like if you have a person with Alzheimer's, they may have trouble understanding the healthcare provider. Patient-related, maybe they're blind, maybe they have trouble hearing. Therapy-related, which may include physical therapy that they may or may not have trouble accomplishing. Culture. This is, again, a very important aspect of patient care that will be discussed much more in your communications class. It involves a shared system of values, beliefs, and learned patterns of behavior, specifies acceptable and non-acceptable behaviors, and offers individuals guidance on dealing with aspects of life. It is dynamic. It is influenced by an individual's proximity to the culture of origin, education, gender, age, and sexual preference. So culture, for example, when I taught in New Mexico, we had a lot of Navajo Indians, and it was considered disrespectful to stare at the patient. You couldn't really look at the patient as you were talking to them. You really had to look at a different direction. That was part of their culture. Health beliefs regarding illness. There's causative factors of illness. Maybe there's some belief in spirits. There's personal views regarding specific illnesses, like perhaps it's because of a sin that they committed. There's health practices like prayer, rituals, folk remedies, herbs, and alternative health practitioners. Like there's a lot of Hispanic healers that I saw in Southern California. There's different communication patterns, verbal, the use of slang, the use of interpreter. Again, you have to be careful when you pick out of an interpreter. Sometimes this may require you to call up a phone company like AT&T and ask for an interpreter to come online to interpret what you say. Again, these are involve a cost, but usually the healthcare payer will provide a reimbursement for that. There's different nonverbal things that go on that have an impact on health, like eye contact I mentioned with Navajo Indians, personal space, and facial expressions. And there's some preferred decision making. So, for example, in California, if you're talking to folks of Japanese descent, usually the women will defer the decisions to the male patriarch of the family. Health illiteracy is a problem. I saw this prevalent in Appalachia. It's the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. 90 million Americans lack necessary literary skills to function in the healthcare system. Now, you could have somebody with a PhD in a particular area, but if they may not know anything about healthcare, so they could be health illiterate. So don't think it's just among poor folks like living in Appalachia. It could be prevalent even in more urban populations. Screening questions for low health literacy include: how often do you have someone help you read hospital materials? How confident are you filling out medical forms by yourself? And how often do you have problems learning about your medical condition because of difficulty understanding written information? But again, it may be that they just don't understand basic health concepts. There's different communication strategies. You should communicate messages at the 5th grade level or lower. A lot of people say 8th grade. No, it's 5th grade. Use the teach back or show me techniques to assess patient understanding. So, for example, you might pour one of the tablets that you're dispensing to a patient into the lid, and have them tell you what you told them about that medication. Encourage patients to ask me 3 times. Write down the instructions and use visually appealing materials. So have those in your consultation area. There's different health behavior models, and these are discussed much more in the textbook. There's locus of control, like who is responsible for my care? Is it myself or some external person who's responsible? The health belief model, what those things that I believe have an impact on my care. The social cognitive theory, which we'll discuss, and the theory of reasoned action and planned behavior. And finally, and most importantly, the trans-theoretical model of change. So the locus of control is the attainment of a particular outcome is either within one's control or outside of it. If it's within our control, we call that internal locus of control. Most of the students in class have a very strong internal locus of control. If it's outside our control, it's called an external locus of control. You believe that the attainment of a particular outcome is outside your realm of control. You would account for it by powerful others like the physician or fate. It's based on Rotter's social learning theory. Potential for a behavior to occur is a function of how likely a particular outcome is to occur and how much that outcome is valued. The health belief model focuses on the likelihood that one will take action or change behavior. Oftentimes, my students have problems distinguishing between susceptibility and severity. So perceived susceptibility revolves around risk. So, for example, if you are of a particular ethnic group, you may have a susceptibility to a particular disease state or condition more for severity. You're talking about the seriousness if the problem is untreated. For one reason or another, students get these two concepts turned around. In the health belief model, you're weighing the perceived benefits and the negatives to change. So, for example, a person who is thinking about an immunization, they may weigh the perceived benefits, like the thought that they won't get a real bad case of flu, to the negatives, like, I might have some arm pain when I get the flu shot. There's different variables that occur that you'll see in the health belief model that are demographic, social, psychological variables, structural area issues, and self-efficacy. Self-efficacy being the confidence in the ability to change. Now, on this particular slide, you need to know some of this for the quiz. There will be a quiz question on IRED number 4 involving this slide. So there's going to be a scenario where there's a patient that comes to your pharmacy all the time and loves to chat with you. He often discusses how he wants to lose weight. One day he's upset and he tells you that his doctor told him that he needs to lose 50 pounds because of his cholesterol and blood pressure being so high. The patient tells you that he's going to join Weight Watchers next Monday and start losing weight. His likelihood to change increased as a result of the doctor telling him he had high blood pressure and cholesterol. Now, I should be quick to point out that susceptibility includes not only your belonging to a particular ethnic group, but it also pertains to how something may be having an effect on your risk. For example, like cholesterol and high blood pressure being really high. So really, we're talking about an increase in the patient's perceived susceptibility and not severity. If in this scenario you had been told, for example, that their cholesterol was something like 500 and their blood pressure was something like 200 over 150 or something like that, that would be more of a severity or seriousness of the untreated problem. Again, sometimes some students mix up susceptibility with severity. Social cognitive theory, there's two types of expectations that influence behavior. There's the outcome expectation and there's the efficacy expectation. Efficacy being the belief in how likely it is that one will be able to change based on performance accomplishments, vicarious experience, verbal persuasion, and physiological state. The key is the individual's perceptions of these expectations rather than their true capability. So there will be a quiz question on IRED number 4 involving this slide. To get your arms around the question a little better, you may want to look on pages 130 and 131 of the textbook and look specifically at table 4-3 and the processes of change. So again, there will be a patient scenario here where the patient comes to your pharmacy and he's upset and tells you that his doctor told him that, again, that he needs to lose 50 pounds because of his cholesterol and blood pressure being so high. He tells you he's going to join Weight Watchers next Monday and start losing weight. Patient joining Weight Watchers and is an example of helping relationships. Again, on page 131 of your textbook, at the very end of table 4.3. There's the theory of reason action, TRA. Intention is a determinant of behavior. Now, one thing you've got to understand is intention is different from actually doing it. It is intentions that are mentioned here, not the actual behavior of taking a medication. So intention does not actually equal some type of behavior like adherence. There are two factors in TRA, the attitude towards performing the behavior and the subjective norm associated with behavior, what other things. Also with in addition to TRA, there's TPB, the theory of planned behavior, because TRA does not address control. So TBP is added to it. The more control one has over the variable involved in the change, the more likely the attempt to change. So the point being, if you're a physician or some other healthcare practitioner, you want to get the patient more involved in the change. They're the ones actually doing a lot of the things that they need to do to remember to take medications and to monitor their blood pressure, their pulse, and so on. The more involved they get, the more likely they will change. Then there's the trans-theoretical model of change. When you get to your communications course, then we'll talk a lot about this. The point being, why do behavior changes fail or succeed? Because there's 5 changes that any patient goes through when they're contemplating change, getting out of a rut, doing things over and over again, knowing full well that it may be hurting them. So, for example, the typical example used when explaining the trans-theoretical model of change is smoking. So there's the pre-contemplation stage before the change is considered. They're uninformed of risks, they're unwilling to change, they're discouraged about changing. Hopefully at some point they start contemplating the change, they weigh the risks and benefits, they fear the costs, negative effects, and failure. Then they move on to preparation. Usually at this point a pharmacist gets involved and the patient plans to take action within 1 month. Then there's the action phase where they're in the process of changing, and maintenance where you try to prevent relapse. There's actually a 6th stage, which is actually relapse, where they actually do relapse into one of the earlier stages. Motivational interviewing was developed by Bill Miller and Rolnick. Bill Miller I knew personally at the University of New Mexico. We did some studies involving motivational interviewing. It encourages a partnership between the patient and health professional. It's used to facilitate behavior change and explores patients' ambivalence to change. The principles, if Bill Miller was talking here, he would say they involve expressing empathy, developing discrepancy. There's rolling with resistance. So Bill Miller likens it to a dance with the patient, where you have these ins and outs when you're discussing their resistance to change. And you avoid argumentation and you support their self-efficacy. Now, there's actually 2 questions that I would like you to understand involving the trans-theoretical model of change and the motivational interviewing. Now, this gets kind of complicated, but going back 1 slide, with the trans-theoretical model, again, I want you to know all of these stages. And one of those stages is called preparation. You would actually see that these stages discussed on pages 126 and 127. But I actually want you to focus in on a no preparation. So again, that patient that's coming in that scenario we keep talking about, we've already had 2 quiz questions. Now you have a 3rd where he tells you he needs to lose 50 pounds because his cholesterol and blood pressure are relatively high. He tells you that he's going to Weight Watchers next Monday and start losing weight. That would be the preparation stage. He plans to take action within 1 month by using this Weight Watchers. Now, intrinsically tied up with the trans-theoretical model of change and these stages of change is motivational interviewing. So again, another quiz question involving this weight counseling. If you're working with a patient who needs to lose weight and he says, what problems are you experiencing because of your weight? What concerns do you have about your weight? What other concerns do you have? This would be an example of motivational interviewing. You're exploring the patient, their ambivalence to change, their concerns, and so on. So when you ask what problems are you experiencing because of your weight, that's kind of developing discrepancy. You're saying, well, if you lost the weight, you wouldn't have these concerns anymore. The pluses and the minuses.